Good morning, everybody. It's an honor for me to be here on this fifth meeting. I've attended each one of them. And I want to thank Dr. Chairman Rogers for giving me the opportunity to be part of this, what I call historical event, in which we have seen really a transformation on the way and the recognition of the problems of addiction in our country, and very specifically on prescription opioids. The prescription opioid epidemic actually has been took the nation by surprise. And it took the nation by surprise because, different from other epidemics of drug abuse that we've had, this one was born out of the healthcare system. And of course, in the healthcare system, and I'm part of the healthcare system, our aim is to help those that are in suffering. And the least thing that we want to do is to create an added problem. And yet, because of the lack of proper training, both in the management of pain as well as the lack of recognition of the importance of substance use disorders as part of the responsibility of the healthcare system, these two phenomena, portraying in pain and portraying an understanding of substance use disorder, is what is responsible for the epidemic that we currently have. And recognizing it is, of course, fundamental in terms of us being able to resolve it, and we can resolve it. I start with this slide that many of you have seen, and you're going to be continuing to see, and we should continue to see it, just as a reminder of the devastating consequences that drugs have in our country. And you see the deaths from prescription opioids, 18,000, and that has the people becoming addicted to prescription opioids are transitioning to heroin, some of them, which now accounts for more than 10,000 people dying annually from overdoses. So that's 28,000 people dying from opioids in this country annually. And to your left, you see actually the number of prescriptions. And I'm putting it there just to get a sense that really it was the excessive prescription opioids that started to increase pretty significantly around 1999, 2000, when it was required by the joint accreditation of hospitals that pain be the fifth vital sign, so that patients suffering from pain could be properly treated. The problem was with that implementation of that rule, there was not an implementation of the proper education of the healthcare providers whose responsibility it was not just to screen for pain, but also to properly treat it. And that resulted in an over-reliance on the utilization of prescription opioids, and basically not just an over-reliance, but a lack of understanding in terms of what these drugs can do and what they cannot do, and very importantly, what are its negative consequences. So why is it that prescription opioids work as potent analgesics? And they are probably the most effective interventions that we have for severe acute pain, and they can be life-saving. So if you have a myocardial infarct, or if you're in a very bad accident and the pain is so intense, you can go into shock if it's not properly treated. And opioids are the most potent ones that we have. So it followed that physicians felt very comfortable saying, well, if it's so effective in acute pain, let's use it also for severe chronic pain. And then they started to feel comfortable, and they started to utilize it not just for severe pain, but for moderate pain, without having the evidence about how to properly use it or its effectiveness. It works, opioids work because they bind to mu-opioid receptors. So the drug interacts with the receptors, producing a signal. And mu-opioid receptors, and you see the images there of a brain where you have the different concentrations of mu-opioid receptors. In yellow areas are regions of the brain that form a network that enables us to perceive pain, which is, of course, extremely important because it gives us information when an organ in our body is being not functioning properly or is suffering from trauma. The issue is that there are mu-opioid receptors not just in areas of the brain that are regulating pain, but there are also high levels of mu-opioid receptors in reward centers of the brain. And this is why when someone takes an opioid analgesic, whether it's OxyContin or Vicodin or hydrocodone, you have decrease in pain, but you also can have a very rewarding, pleasant sensation, because the drug is not discriminating, it's binding everywhere in the brain. So it's producing this analgesia, but it's also producing a very intense pleasurable response. We also have high concentrations of mu-opioid receptors in the brainstem, which is the lower part of the brain, which actually is responsible for regulating our breathing. And you don't have to pay attention or consciously or do anything by breathing. This is an automatic response. But when opioid drugs bind to the opioid receptors in this brainstem, they inhibit that nuclei, that region of the brain that allows us to breathe. And that's the reason why people die with an opioid overdose. They stop breathing. There are opioid receptors also in many other areas in our body, and those are responsible for some of the side effects associated with them, like in the gastrointestinal tract, constipation. And it's actually important to know these characteristics of opioid to try to come up with solutions. A question that has ultimately the way that we use logic is in terms of physicians, and there are many misunderstandings out there in terms of the use of opioids. For many years, it was believed that if you have pain, and you were taught in medical school this, I certainly was taught this in medical school, that if you have pain and you get an opioid drug, you're not going to become addicted to it. Unfortunately, this is not correct, and the epidemiological studies are showing that indeed a non-negligible number of people who have pain, who are properly prescribed the opioid, become addicted to the medication. Not everybody becomes addicted to the medication. And we don't know exactly what numbers are, and it varies from survey to survey. But in conservative terms, it is estimated that approximately 8% of individuals that are prescribed opioids will become addicted to them. But the great majority does not. And the question that has emerged is, why do some people become addicted and others do not? And there are many factors that determine if you're becoming addicted or not, including your age. So teenagers, for example, are at much greater risk of becoming addicted to medications or to drugs than a person that's an adult, because their brain is much more plastic, and so it changes faster. There are other elements that make you vulnerable. High stress conditions increases your vulnerability for addiction. But we also recognize that genetics play a very important role in those that become addicted and those that do not. And it's estimated that that contribution is approximately 50% of your risk is related to genetic factors. And we're funding a lot of research to try to understand what are the genes that make you vulnerable to addiction. Because of course, if we knew them, if we have such a test that would determine who's at risk based on genetics, you could actually then do particularly careful and be certain that if you don't need to prescribe it, don't prescribe it. But if you're going to prescribe it, to monitor very carefully. And this is one of the genes that has been associated with vulnerability for addiction. It is a gene that encodes for the protein, for the mu-opioid receptor, which has a variant that, if you have that variant, which we call the 118G allele, it leads to lower concentrations of the mu-opioid receptors in the brain. And interestingly, that puts you at higher risk for addiction, not just to opioids, but also actually, interestingly, a higher risk for addiction to alcoholism. And it's also associated, has been associated with a higher risk for overdoses. At this time, we are unable to determine with any certainty which patients are at greater vulnerability to become addicted versus those that we do know, that do not. We do know, though, that individuals who have a history of a substance use disorder where it's legal or illegal, addicted to tobacco, addicted to alcohol, addicted to heroin, those individuals are at a significantly higher risk of addiction if they are given an opioid analgesic. And this should be one of the screening questions that should be placed on patients in whom a physician is considering providing an opioid. So how can research, because the National Institute on Drug Abuse, its mission is to develop knowledge that can help solve solutions. We are an institute whose mission is science, and science provides us with solutions to address the problem, but also to generate knowledge that can help guide policy. And I'm going to actually give some examples specifically about how can science help us now address the problems that we're facing on the prescription opioid epidemic, but also how it can help us in the future avoid and prevent the current situation by providing transformative solutions. So science can come up with solutions that can be implemented now, and can come up with solutions that are transformative and in the future will change the way that we address the problem. And I'm going to give the presentation following the HHS strategy of how to address this epidemic. Improve prescription practices for opioid, expand access to naloxone so you can prevent overdoses, and expand access of medication-assisted treatment so you can actually help those suffering from opioid addiction. In the area of pain, what we know with respect to mu-opioid receptors, I told you they are located in high concentrations in regions of the brain that process reward. But we know that opioids actually, and the same is true for all of the drugs of abuse, where their potential for producing rewarding effects, their potential for producing addictiveness is dependent, of course, on the doses that you take. Higher doses are going to produce a more intense reward, but also, very importantly, on how fast they get into the brain. And this has to do with the way that the brain signals pleasure. The faster the drug gets into the brain, the more powerful its rewarding effects and the greater its addictiveness. And this explains why, when people abuse opioids, they like to inject it, because the injection will lead to very fast uptake to the brain, and that will produce a very intense high. And this characteristic actually is the basis of why one of the strategies for addressing decreasing the likelihood of opioid drugs to be abused is to create new formulations that cannot be injected in such a way that the drugs cannot get it rapidly into the brain and thus prevent these rewarding effects while making them quite effective analgesics. So this is one of the most frequently utilized strategies by pharmaceutical industry as well as by researchers to try to address how can we provide opioid medications that have analgesic properties that are safer, that are abuse, what the FDA calls abuse deterrent formulations. So the abuse deterrent formulations, most of them, are to actually develop ways of delivering the opioid in such a way that you cannot tamper it, and that's why they are calling it tamper resistant. You cannot extract the active ingredient and inject it. And multiple strategies are being done. One of them is prodrug. The drug will not be active until you, for example, ingest it. And once you ingest it, the enzymes in your gut actually cleave it so you can then make it active. Another one is to embed it in polymers that you cannot extract it and then inject it. And another strategy has been to combine the opioid with a substance that, while you take it orally, has no negative effects, but when you inject it, will provide actually a negative reaction. Another strategy, and for which there are no current examples, but researchers are investigating this alternative as well as pharmaceutical industry, is to take the opioid and chemically modify it so that even if you inject it, it gets into the brain very, very slowly, and those will have minimal rewarding effects. But beyond the use of alternative ways of delivering opioids, we are also investing significant resources in developing alternative targets that can be used for medications other than opioids for the management of pain. And in that respect, for example, a very interesting potential compounds are cannabinoids that actually work through the endogenous cannabinoid system. So just like we have our endogenous opioid system that regulates pain, so we have also the endogenous cannabinoid system, which is another chemical in our brain that allows us to modulate pain responses. And there are also strategies that aim at changing the excitability of tissue as a strategy also of modifying neuropathic pain. We're also investing in strategies that are non-medication based, that look at stimulation of the brain to actually inhibit the areas of the brain directly through electrical or magnetic currents that are responsible for us perceiving pain. as well as behavioral interventions that enable us through biofeedback mechanisms, for example, to regulate the intensity of perception of pain. And one of those strategies that has generated, as of late, a lot of attention is the use of meditation practices. What about overdoses? And we've all been hearing a lot about naloxone, and we're very lucky to have a chemical compound, which is an antagonist. So it binds to the mu-opioid receptor, and it basically pushes out, displaces the drug. And in the brainstem, when it displaces the opioid, whether it's heroin or Vicodin, OxyContin, that's exactly why you are reverting the opioid overdose, because the patient, then the moment that you remove that inhibition, is basically able to breathe again. But the challenge about the use of naloxone is that basically, traditionally, you're required to inject this drug. And so there's been a lot of interest to develop ways of administering through syringes, through the nasal cavities, so that people that are not in the healthcare system, that do not know how to properly do injections, can apply naloxone. There was also a product that is an auto-injector that will allow individuals that are not trained in proper injection practices to be able to deliver naloxone. But this is a space where we want to make naloxone as widely available as possible, and that means accessible to anyone with no medical training. So what we've done at the Institute is partner with 2 pharmaceuticals to help them develop a user-friendly intranasal spray that actually delivers the naloxone. But here it is important for you to realize that for us to be successful on reverting an overdose, we need to administer naloxone as fast as possible and in a way that will deliver the drug very, very rapidly and at high concentrations in the brain. And you see a curve there that actually was responsible for the approval of this product by the FDA that shows the intranasal delivery systems that we've been helping fund, which is called intranasal Narcan, and is the concentrations of naloxone in the blood versus that of the injectable. And you can see that the product actually delivers significantly higher concentrations, extraordinarily rapidly, and faster, actually higher concentrations than the intramuscular injection, providing a very effective way of delivering naloxone that anyone can apply and extraordinarily accessible. $37.50 per nasal spray. And so people ask me, are you actually in favor of having nasal Narcan over the counter? And I said, yes, absolutely. I'm in favor of making it as accessible as possible. And if that means over the counter, over the counter. And the counter arguments that I've heard is people say, Nora, you are missing the opportunity of doing an intervention and sending that patient to treatment by giving them a nasal Narcan or their relatives or their friends. My perspective is if that patient dies, I'm not going to have a chance to send them to therapy. However, we need to be mindful that one of the factors that predict who's going to be in an overdose is having had a past history of an overdose. So when we are able to revert an overdose, we need to be conscious that we have to take that moment to send the patients to proper treatment. Because if not, it is very likely that that individual in the future will undergo a second overdose. The third and last aspect of, that I want to address is that of addiction. And in this space, I want you, again, to familiarize you with the current medications that we have for the treatment of addiction. Of medication-assisted therapies, and they come in 3 flavors. The full agonist, which is the one that most of you know, which is methadone. Then we have buprenorphine, which is described as a partial agonist. And then we have antagonist medications. So what is the difference? A full agonist, like methadone, is a medication that binds to the mu-opioid receptor, and it doesn't have to bind all of the receptors in our brains in order to produce a strong effect. In contrast, a partial agonist like buprenorphine is a medication that needs to bind to all of the receptors. If it binds to all of the receptors, it will never have the same effect as a methadone because it just has partial potency. An antagonist is devoid of any effect, and the only thing that it does is occupies the space of the receptor so that heroin cannot bind or any other drug cannot bind. There has been a lot of rejection of these medications from ideological perspective and for misunderstanding. So this is the second misunderstanding in this whole space, that it is believed that you're substituting one drug for a medication, for another drug, and this is incorrect. Buprenorphine and methadone are drugs that are given orally, and as a result of that, they produce stable labels and do not have the strong, highly rewarding effects that you get when you inject heroin or you inject other opioids, but it allows your brains to stabilize itself. The problem is that on these medications, when they are implemented, whether it's methadone, buprenorphine, and as of more recently now data with Vivitrol, which is the antagonist, the slow-release formulation, have been shown to prevent overdoses. So we know that they are effective in helping the person avoid relapsing. They are effective in helping them avoid an overdose, and they are helping them also in preventing getting infected with hepatitis C of HIV. But we're not using them. And even in specialty treatment for substance use disorders, it is estimated that at least 1/3 of those programs will give access to medication-assisted therapies. And this reflects, again, this misunderstanding and on the perspective that you are just giving one drug for the other on the one hand, but also on the other one, in a lack of understanding really about how these medications work and the lack of infrastructure. So what we've done in this space is actually help develop medications that will be easier to comply with. A perfect example is buprenorphine through an extended release formulation that will allow the individual to be treated every 6 months with an implantable. And you can start to think the difference, the transformation that generates in terms of the space of a person that has to go to receive their medications on a daily basis. Imagine if you're in a rural community where there's no access to healthcare system, where there are no methadone clinics. Access to once every 6 months will allow that person to have access to treatment. Similarly, in the criminal justice system, where there is basically a rejection of the use of medication-assisted therapies, particularly of the agonist, access to the antagonist, the extended release formulation of antagonists like Vivitrol, which requires injection once a month, provides an alternative that's much more accessible to its utilization. And actually, it's already shown in the criminal justice system that implementation on Vivitrol significantly reduces the likelihood of relapse on the one hand, and also significantly protects the individuals from overdoses. So another aspect about it, and which has been discussed at these sessions, is that medication-assisted therapy, there's not sufficient infrastructure currently available to treat all of those people that are in need, even if it is accepted by the community. So we are looking into infrastructures that are currently already there, which we could take advantage of in order to implement the treatment of medication-assisted therapies. One of them is illustrated working with the emergency room physicians, showing that this very simple intervention, a patient ends up in the emergency room with an overdose, and you implement buprenorphine treatment there in the emergency room. And in this study, for example, they compared that very simple intervention to that of referring them to treatment to get their buprenorphine outside the emergency room. And they observed double the likelihood of patients staying in treatment, but that instituting the treatment while in the emergency room. Similarly, studies that are working with individuals that have an infectious disease, HIV, that are involving the infectious disease clinics in the administration of the buprenorphine have also shown double the retention by that simple interventions. And I want to end up my talk by actually coming back to the very simple strategy that we need to implement and the urgency to implement it. And I'm showing this slide so you get an idea about how important it is that we implement education for providers on the one hand on the proper treatment of pain, and on the other one on the proper recognition and screening for substance use disorders. This was a recent study that was published where investigators look at the outcomes of patients that ended up in the emergency room with an overdose from an opioid. who didn't die. And they followed them for several months after that episode. And they actually monitor what happened to that patient vis-a-vis that actually their prescription of opioid medications. You know, there are many guidelines that have come out in the proper use of prescription opioids. And the CDC guidelines, which are the most recent one, actually basically have advanced further the recommendations on how to properly utilize these prescription opioids. The problem is that you have guidelines. It does not mean that you're going to use them. And this illustrates that. Here you have in different colors, the first, when the patients go to the overdose, they look at what were the doses that patients were receiving. In red are those individuals receiving high doses, and that's 100 milligrams of morphine equivalent or more. Now, all of the guidelines that you read will tell you you should avoid using these very high dose of morphine milligram equivalents because they are associated with an extremely high risk of overdose. You should rarely use it. And you see there that almost half of the patients that ended up there have those high doses. In blue are individuals that are receiving 50 milligrams of morphine equivalent or more, again, associated with high risk of overdose. Well, you would think if a patient has an overdose, and all of the guidelines tell you if you have an overdose, the physicians have to consider whether, in fact, that patient should be brought back into an opioid. And if they are brought back into the opioid, you should really reconsider giving those high doses, which are associated with higher risk. What these investigators showed during their follow-up for close to 2 years is that after the overdose, most of those patients continued to be prescribed these very high doses of milligram morphine equivalents, even though they had undergone an overdose. And they followed them, and even though they underwent a second overdose, they continued to be prescribed those opioids at high doses. And you can clearly see to your left, actually to your right, that as you had predicted, those patients, 20%, close to 20% of patients that were given these high doses or moderate, more than 50 milligrams of morphine equivalents actually underwent a second overdose that would have been prevented had those prescribers followed the guidelines that are currently available that actually indicate if you have had an overdose, you're at much greater risk of getting an overdose, and when you have someone having adverse effects of opioids, the physicians should consider actually whether those patients should merit being tapered off of their medication, and if you cannot taper them off, significantly decreasing the doses that you are using. And again, highlight the incredible importance of instituted proper training of healthcare providers in the management and screening of pain and in the management of prescription opioids. NIH and NIDA, in partnership with the Pain Consortium, we are funding throughout the United States centers of excellence for the education of pain, such that nurses, pharmacists, dentists, medical students, and specialty physicians are better able to screen properly for patients with pain and to properly prescribe opioids when needed. And we're also creating centers for excellence for the proper training of healthcare providers in the screening and understanding of addiction. We can solve this epidemic, and we can solve it, and we need to solve it promptly. I don't know what the numbers yesterday were. There was actually, when we started, I don't recall exactly what it was, but those numbers, and I've been looking at it, keep on climbing as we are speaking here. And if we think what it means, it's a number there. It's a person that dies of an overdose that should have not died. People that are dying from overdoses of opioids should not die. We know what is producing it. We have antidotes. And we know that proper prescription practices, proper access to the correct medication, and proper treatment of those that become addicted, those are tools that we currently have. We need to implement them, and there is an urgency in doing so. Thanks very much for your attention.